Module 9, infection, concept of infection. So we'll be covering quite a few things in the pharmacology here. So in your concept section of Module 9 on page 582 to 583, it lists a bunch of antimicrobial agents. And then later when we get into the tuberculosis drugs in this module, 9G of tuberculosis, they have chart of drugs for tuberculosis, page 648 to 649. Okay, so let's get started. Anti-infectious drugs that are designed to act selectively on foreign organisms that invade the body. So they're antibiotics to kill a bacteria, antifungals kill a fungal, antiprotozoal kill what is the word I want? A protozoa is disease, dysentery and malaria, antihelminthics, those are like worms, antivirals, oops, hit the wrong button, antivirals and antimycobacterials. So the antimycobacterials are in the TB section here. So antibiotics, several different classes. Antibiotics are antibacterials, and they inhibit the growth or destroy a microorganism. They can be bactericidal in that they kill it, bacteriostatic in that they inhibit the growth. All antibiotics are bacteriostatic, but not all are bactericidal. Both, when you compare bactericidal to bacteriostatic, there's no difference in their clinical outcome. So antibacterial actions is they target different parts of the cell wall, and the resistances form in here where they can't break through the wall. Penicillins or beta-lactams is your penicillin group. All beta-lactams bind to and inactivate enzymes required for bacterial cell wall synthesis. Contraindicated if there's a drug allergy or possible cross-sensitivity. It's like a 60% cross-sensitivity to the next class of drugs of antibiotics called the cephalosporins. Most common GI and skin, so rash is actually common, not necessarily it's more of an adverse than it is an actual allergic reaction. If somebody says they're allergic to penicillin, which many people do, I always have to list what kind of reaction, but don't argue with them. And common with the penicillin, if you're used to get a oral or vaginal candidiasis or overgrowth of yeast. Drug interactions, it decreases the effectiveness of contraceptives and rifampin. Rifampin is a drug used in TB. Increases the effects of warfarin, which is Coumadin, which is a blood thinner. Examples of the penicillins: amoxicillin, amoxicillin clavulanate, nafcillin, ampicillin. If you notice, the cillins have the cillin in their name. Next is your cephalosporins. That's your next class. They're bactericidal. They're very much like the penicillin. There's 5 generations of cephalosporins. Contraindicated, of course, in a drug allergy and a possible cross-sensitivity to penicillins. Same adverse effects of GI and skin, oral and vaginal candidiasis. Drug interactions, acute alcohol intolerance, dysfullerim-like. So in mental health, when you listen to this, I'm not sure if we had covered it yet with your drug and alcohol. Disulfiram is used to prevent or as a deterrent for alcohol intake of alcohol in the alcoholic. If they were to drink alcohol when they're taking this, they get violently ill. And so cephalosporins taken with alcohol, they will have that same effect, violently ill. If cephalosporins are blocked, the absorption is blocked if they're taken with an antacid. And just like penicillin, cephalosporins will decrease the effectiveness of contraceptives, so you want them to abstain until after the antibiotic and 7 days back on their continued use of their oral contraceptive or any contraceptive, or to use a secondary barrier contraceptive. Some common cephalosporins are cefazolin, cephalexin, ceftriaxone. Ceftriaxone or acefin is the only one given IM. The rest are IV. The other two are oral only. Cephalosporins tend to have the ceph in their name, whether it's a CEF or CEPH. If you see that in the name, you can be pretty darn sure it's a cephalosporin. Moving along, next class are your macrolides. Bacteriostatics, I should have said bactericidal at higher doses, sorry about that. Inhibit the protein synthesis, that's how they work to keep the bug from duplicating itself. Contraindicated in a drug allergy. Adverse effects, GI, especially erythromycin. Erythromycin is a biggie for getting people to vomit and diarrhea and cramping. Other adverse effects, palpitations, chest pain, headache, dizziness, rash, phlebitis at the injection site if it's given IV. Hearing loss and tinnitus, keep those in your mind for your macrolides. Your macrolides are your thromycins, or ithromycins, I guess you could say. Not the mycins, but ithromycin. If you see ithromycin, it is a macrolide. Azithromycin, clarithromycin, erythromycin, all of them are pretty stinking potent on the gut. Azithromycin, not quite as much. Azithromycin's the nice one people call a Z-Pack, where you can take it for once a day for 5 days. The rest are not that way. Both of these are tough on the gut. Clarithromycin is one that's more at risk for developing C. diff with it. They're pretty stinking potent. Highly protein bound. Remember, if they're protein bound, there's a risk with the low albumin, the levels getting too high. They also decrease effectiveness of contraceptives, so that's your generalized teaching with any antibiotic use. Enhanced effects and potential toxicity. Look at these for carbamazepine, that's your anti-seizure drug, or Tegretol. Theophylline, aminophylline, and your warfarin or Coumadin. Warfarin or Coumadin has a problem with a lot of the antibiotics. A lot of times when people are on an anticoagulant such as warfarin, the nice thing is if they go to what's called a Coumadin clinic that's monitoring them, and they should let their Coumadin clinic or whoever's monitoring their warfarin PT-INR levels know when they go on an antibiotic so they can make appropriate adjustments. Okay, your tetracyclines. Bacteriostatic. Contraindication of drug allergy here, unlike the others. Contraindicated in pregnancy, lactation, and children under the age of 8. Completely contraindicated in that. It will cause major problems in the baby. Adverse effects, discoloration of permanent teeth. There was a time when this was given in an oral form and a liquid form to children, and they had permanently discolored teeth. One of my best friends had that problem. Major photosensitivity, so what are you teaching them? They are not to get in the sun. They need to use major sun blocker, but avoid being out in the sun when they're on tetracycline and for like a week coming off of it. Diarrhea is common, vaginal candidiasis or yeast, and GI upset. So doxycycline is your tetracycline. Doxycycline. Again, you have your cycline in the name for your tetracycline. Reduced effectiveness if given with anything that blocks that absorption, enteral feedings, antacids, dairy products, calcium, and interesting enough, iron will block absorption of tetracycline. Increase effectiveness again of your anticoagulants, decrease effectiveness of contraceptives. So that's pretty much across the board on increasing your effectiveness, risk for bleeding if you're increasing your effectiveness of your warfarin or Coumadin. Sulfonamides, your sulfa drugs, which I mentioned sulfa drugs way back in your anti-diabetics when I talked about your sulfasalazine. Okay, so your sulfonamides inhibit bacteria. Contraindications are drug allergies. And interestingly enough, if you're allergic to Celecoxib or Celebrex, which is a COX-2 inhibitor, sulfa drugs are contraindicated. Contraindicated in pregnancy in infants under 2 months old. So sulfonamides and tetracyclines are contraindicated in pregnancy. The example of a sulfonamide is your sulfamethoxone, trimethoprim. It's a combination, or commonly known as Bactrim. It's very, very common to have an allergy to sulfonamides, especially Bactrim. The ones I've seen, they tend to be a pretty pronounced reaction, like welts, trouble breathing, almost anaphylactic. Causes blood dyscrasias. Blood dyscrasias, something's off with your platelets or your white blood cells, like your lower white blood cell, lower red blood cell, lower platelets, blood dyscrasias. Nausea, vomiting, diarrhea, and pancreatitis. Photosensitivity. What's the other one? Tetracycline. Both of those, photosensitivity. Severe skin reactions are common. I will cover that, I think, at the end. Somewhere in this unit, I cover those skin reactions. Drug interactions potentiates hypoglycemia with sulfonylureas. So sulfonylureas can also be a cross allergic reaction, and it potentiates the hypoglycemic effect or the drop in your blood sugar. Toxic effects in phenytoin and warfarin. There's your warfarin again on every antibiotic, and can decrease your effectiveness of your contraceptives. So what is this person? If you have blood dyscrasias, you're watching your CBC. So you're looking for your white blood cells, your red blood cells, and your platelets. Aminoglycosides. NCLEX and Kaplan love aminoglycosides. Nephrotoxicity and ototoxicity. Very common. Watch for those, watch for those, watch for those. Work synergistically, so often will be given in combination with other antibiotics for really significant infections. Contraindicating drug allergy, again, no in pregnancy, lactation, along with your tetracyclines, and your sulfonylureas. Nephrotoxicity, ototoxicity, drill that in your brain. You will hear that, see that over and over for your aminoglycosides. Headache, vertigo, skin rash. Pretty common, but watch for these two. So which are they? That's when I said don't think of the others as your mycins, because your aminoglycosides are your mycins. Gentamicin, streptomycin, tobramycin. Usually IV on these. All of these aminoglycosides will decrease your absorption of vitamin K. So if it decreases your absorption of vitamin K is your, what do you call it? Can't think of the name. It reverses the effects. So if your Coumadin warfarin level is too high, your PT-INR is too high, risk of bleeding, you reverse it with vitamin K. So if it decreases absorption of vitamin K, you can figure aminoglycosides are going to increase the effectiveness of your warfarin and increase your risk for bleeding. Therapeutic drug level monitoring. Again, you are looking for nephrotoxicity, ototoxicity. Don't worry about what the levels are for these. Just know that you're doing therapeutic drug level monitoring. This is the ones you're going to be doing peaks and troughs. I'm not sure if peaks and troughs have been covered. peak is when the drug reaches its peak level in the body. So a peak is drawn usually 20-30 minutes after the IV dose has started to be administered. It is infusing. They're given over a long period of time, usually like 45 to 60 minutes. So you start the drug about 20-30 minutes in, you're drawing a drug level. Your trough is down in the trough, down in the gutter, down when it's lowest. So your trough is drawn right before your next dose is given. And a peak and trough will be ordered in the hospital. These are given. Those are usually managed by pharmacists, and you will see orders with the next level dose to be given and when to draw the peak and the trough before. It might say a trough, peak and trough before with the fourth dose. So you do a trough before it, a peak as soon as you hang it, shortly after you hang it. And you will forget one of these times, and you're going to kick yourself and have to call the physician or the provider and the pharmacist, and you don't know what your levels are, and it's a real crappy thing. So peak and troughs, that will be asked probably on Kaplan, very likely will be asked on your NCLEX. Your trough is down when it's the lowest before a dose. Your peak is shortly after the dose is started. They're given over a long period of time, IV, in a large dilution of fluid. Next class, your fluoroquinolones. We are almost there. So fluoroquinolones, or quinolones. That's supposed to be sorry, there's another typo there. Bactericidal goes after the DNA, contraindicated if there's a drug allergy, adverse CNS headache, dizziness, insomnia, convulsions, because it lowers the seizure threshold. As I probably have said before, everybody has a seizure threshold. People with seizures have a lower seizure threshold. So people with a seizure disorder are higher risk, and be careful with fluoroquinolones because it's going to decrease their seizure threshold and increase the risk for convulsions. Nausea, vomiting, diarrhea, candidiasis, headache, nausea, vomiting, diarrhea, common with fluoroquinolones. Rash, pruritus, flushing. Big thing here, ruptured tendons. No other antibiotic will do that. Ruptured tendons. The most common, I think, is the Achilles, but they can rupture a tendon while on or shortly after the use of a fluoroquinolone. Your fluoroquinolones have fluoxetine in their name, ciprofloxacin, levofloxacin, fluoxetine in their name. Those are your fluoroquinolones for your fluoxetine. Decrease absorption with antacids, dairy products, calcium, enterophenols, and iron. If you recall, you saw that on a previous one. That was on your tetracyclines. Anyway, so fluoroquinolones commonly use the ciprofloxacin, levofloxacin. So before I go on, I'm not worrying about you knowing which class of antibiotics works best in which part of the body. That really is beyond your scope, just having a good understanding. But in your patient teaching, one antibiotic doesn't invade every part of the body. There are specific antibiotics used for different parts of the body. So just what's good for one may not be good for another. Some are good in the lungs, some are good in the bladder, some are good in the gut, some are multiple places. There's broad spectrum versus these narrow spectrum antibiotics. Also very important in your teaching, always tell them to take it till it's gone, not to stop it abruptly, because then you're increasing that risk of having an overgrowth or a resistance building, because it's working on that cell wall somewhere in the structure, the DNA and the RNA. And so if they stop it, then they increase the risk of antibiotic resistant building, which we're up to. We've got methicillin resistant, which is your penicillins. Your VRE, which is your vancomycin resistant. I know there's a bunch of TB ones that are resistant. We're developing HIVs that are virals that are resistant. Anyway, it's becoming almost pandemic in itself. C. diff, Clostridium difficile. The normal gut flora is altered by broad-spectrum antibiotics, clindamycin, cephalosporins, the penicillins, and fluoroquinolones are the most common I said that clindamycin's a biggie. Pseudomembranous counts, yellow plaque form over damaged epithelium. If you've not seen this, smelt it. Once you smell it the first time, you will never forget it. It lives on counter surfaces for ages. So it is transferred that way. So you're using contact precautions. It's not airborne, but every surface. And yes, this is a disgusting diarrhea, foul, 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 foul. Very, 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 very contagious. Make you very sick. Metronidazole. Metronidazole, bactericidal anti-protozoal amebicide. So it's for those some different kinds of infections, such as what is it? Bacterial vaginosis or BV, and trichomonas, and maybe in malaria. Contraindicated first trimester of pregnancy, very important because they may not know they're pregnant when somebody has bacterial vaginosis or trichomonas. It is used to treat pseudomembranous colitis, which is your C. diff. Adverse effects, anorexia, nausea, abdominal cramps, monitoring those liver enzymes. So it will be contraindicated if they've got renal liver failure or maybe an alcoholic. Interactions, alcohol disulfiram effect. So your metronidazole and your cephalosporins. Never, ever, ever take either of those. Major patient teaching not to drink alcohol when you're on it, not for a week after you finish antibiotic. Even though somebody finishes their dose of antibiotic, that antibiotic is still working in their body for a matter of days to a week after. Increases effects of anticoagulants, your warfarin, there you go again. Warfarin may cause some bleeding problems, increased PT-INR, and dose adjustment will be required. Here are, oops, I hit the wrong button. There. Here are major complications. Erythema multiforme, Stevens-Johnson syndrome, toxic epidermal necrolysis. I have seen all three of these listed on different reviews for NCLEX and dispersed through Kaplan. This multiforme is most common on the hands and forearms, oral lesions about 50% of the time. Stevens-Johnson syndrome, these cover very little of the body surface. This toxic epidermal necrolysis covers more than 30% of the body. This one most common in children, Stevens-Johnson syndrome. It's upper respiratory-like syndrome, most due to drug reactions. To qualify, it has to be more than two or more mucosal sites of the body, and they're admitted to a burn center. This toxic epidermal necrolysis covers more than 30% of the body, usually in the elderly. HIV's increased risk, abrupt onset. Mucosal membrane involvement, admits a burn unit. The Nikoliski is where you're putting pressure on the area, and the underlying eroded base of the wound is moist or glistening, considered wet. And then that's a positive Nikoliski sign. Anyway, this toxic epidermal necrolysis, I know, boy, where was I working? I've got to think of what year it was, way back in 90, 92, no, maybe earlier than that, 90, no, 88. Anyway, we had somebody come into the unit, had an allergic reaction to phenytoin or dilantin, and she had these huge blisters. This toxic epidermal necrolysis will blister, and she had these huge blisters on her body. She looked like she had been burned. We didn't know what it was. We didn't have that name at that time. All I could say is it looked like her body burned from the inside out. It covered probably 90% of her body. We were doing these moist dressing changes on these blisters as they were bursting, and she was screaming, and we did end up sending her to a burn unit. It was the most awful thing I've seen and that's toxic epidermal necrolysis, and she had it in response to phenytoin and dilantin. Okay, so for the most common drugs to cause these major skin reactions of erythema multiforme, Stevens-Johnson syndrome, and TEN, you'll hear it called TEN, toxic epidermal necrolysis, PCP labs. So here's a lot of your anti-seizure drugs: phenytoin, carbamazepine, phenobarbital, and lamotrigine. Phenytoin is dilantin. Carbamazepine is tegretol. Phenobarbital is phenobarbital. Lamotrigine is your Lamictal. I kept wanting to say that and didn't want to say that. Okay. Your antibiotics, penicillin, sulfa, erythromycin, allopurinol, which is a drug used for gout. I don't think we get into that this semester, but anti-seizures and 3 classes of your antibiotics, but seizure meds. So you're going to teach them to be looking for these signs so we can stop it before it gets real bad. Okay, going to keep moving. Antivirals for influenza. So your influenza is exemplar 9C. I was just looking here, but I don't actually see a chart of the drugs in your text. They list some of them in a little paragraph here, but that's about it. All I see is the safety alert at the top of page 610. Your zanamivir is contraindicated patients with chronic respiratory conditions such as COPD and asthma. Oh, because that's the live vaccine that's given in an inhalation. Okay. Let's keep going. Oseltamivir and zanamivir. AMIVIR. Amivir antivirals. These are your Tamiflu and Relenza are the brand names given for influenza A and B within, why did I put within 2 weeks of onset of prophylactic? Oh, I guess that's what the manufacturer says, but the CDC says within 48 to 72, we'll say 72, it's 48 to 72. So within 72 hours of onset. Prophylactically, it can be given. They're given twice a day for 5 days for treatment. They're given once a day for 7 days for prophylactic if they've had an exposure and they're high risk. Your oseltamivir or Tamiflu is the only one given for 2 weeks old and older. You may see that in a question, zanamivir, age 5 and older, but your Tamiflu or oseltamivir, age 2 weeks and older. Adverse effects: nausea, vomiting, colitis, and actually pneumonia. And hang on, let's see. Let's keep going. Oh, I didn't hit. I thought I hit it. Antimicrobial drugs for TB. So your TB module is way back in 9G. They have a bunch of the drugs listed, table on page 648 and 649. And I'm not covering the med surg behind it, just the drugs for management. Isoniazid or INH, bactericidal, mainstay of treatment, single or in combination. Contraindications: previous isoniazid liver injury, hepatitis, and gout. Those are the people that can't get it. They do a baseline liver enzymes, and then they monitor after use. So they might see an immediate increase in liver enzymes, and then it should go back down. If it does not, there's a problem. I happen to know because I'm one of those people that can not take isoniazid. I was given it way back. Let's see. Before I was pregnant with my son, who's now 27. So more than 27 years ago, 28, 29 years, whatever, I got exposed, had a grossly positive PPD skin test, negative chest x-ray. At that time, they were treating everybody anyway. I was put on isoniazid. I do not drink alcohol. My liver enzymes spiked after 2 weeks. The nurse told me, okay, be careful, we'll check it again in another 2 weeks. I didn't make it the other 2 weeks. I went into an acute hepatitis, got so sick, liver enzymes went out the roof, had to go off of it, thankfully. It took about 2 years, but my liver enzymes went back to normal, but I am missing an enzyme to metabolize. So isoniazid, or INH, is contraindicated for me. Anybody that is on it causes pyridoxine or B6 deficiency, so they have to be on pyridoxine supplement throughout the time. Peripheral neuropathy, that's because of that B6 deficiency. Hepatotoxicity, big time. Optic neuritis, visual disturbances, those are adverse effects that need to be reported immediately, and it can cause hyperglycemia. So, of course, somebody that already has hyperglycemic, the diabetic, use with extreme caution and monitoring. Drug interactions, antacids reduce absorption. And see this, your two anti-seizure drugs. It increases the levels of your phenytoin and carbamazepine, so those will have to be closely monitored. In your text, it gives some more on your isoniazid. Yes, it is often given in combination with rifampin. Evidence of anemia, bruising, bleeding, or infection due to agranulocytosis, which means blood dyscrasias, where it decreases your platelet count, your red blood cells, possibly you're decreasing your white blood cells. It gives you some more drugs. Increased risk of toxicity with diazepam, which I didn't have on here. So add your diazepam, which is your Valium. Increases the levels of that. Health education, yes, take it the entire treatment, no interruption because of resistant strains. Reportable adverse effects, add your decreased appetite, nausea, jaundice. Already told you, taking your pyridoxine or your B6 to prevent that peripheral neuropathy. Avoid alcohol. Anything that's going to mess with your liver is very important in your teaching. Prevent pregnancy because it's very harmful. It's contraindicated in pregnancy. Don't worry about your myambatol on this chart. We're going to stick to your isoniazid or INH. So keep moving. Your rifampin. Don't worry about your pyrazanamide. Go right to, skip the other one, go right to your rifampin on page 649. Don't worry about brand names. I've always known it as rifampin. Oral or IV, usually it's oral because it's done on an outpatient basis. Teaching must be taken on an empty stomach. Oh, hang on. I'm getting ahead of myself. Contraindication is a drug allergy. This is a common question. It causes urine, saliva, tears, and sweat to get a red-orange color. That is normal. So obviously you're going to teach them. Again, it can cause hepatitis and hematologic disorders with decreased platelet, decreased white blood cells such as granulocytosis and decreased iron stores. Drug interactions, multiple. There you go with your phenytoin again, oral anti-diabetics, just like your, what was it? I don't know. Oral contraceptives, anticoagulants, your Valium, your benzodiazepines, decrease effectiveness. So your INH will increase the effectiveness of your benzos, but rifampin decreases the effectiveness of them. So it decreases effectiveness. All these often given in combination with your INH, so you're really watching that liver. What else does it tell me in here? Given on an empty stomach. Some more things to add to this listed in your text. Administer on an empty stomach. I have the drug interaction decrease effectiveness, the oral contraceptives. I have add your corticosteroids and your digoxin because I did not have those on there. told you about the hypoglycemic drugs or anti-diabetic drugs. The avoid using soft contact lenses because they will be permanently stained with that red-orange. Do not miss or skip doses because they will lead to a flu-like syndrome and a fever when you restart the drug. Major teaching there, absolutely no aspirin because while you're taking this because of the interfere with rifampin absorption. And the last part, fever, flu-like symptoms, excessive fatigue, sore throat, unusual bleeding may indicate an adverse reaction to the drug. Reported immediately. That's a big thing to do with your blood dyscrasias. Okay, and that is the only one. The rest of these drugs listed here, I'm not worried about. It's just your INH, isoniazid, and your rifampin, which are the mainstays of TB treatment. We're not getting into all the multi-dose and everything else that's covered a little more in your community. That is the end of this recording.